Final presentation, I'd like to introduce Dr. Brian VenderBrink. As you know, Dr. Weiss is my partner and a consultant, and Dr. VenderBrink is Dr. Pramod Reddy's partner and also a consultant at Cincinnati Children's Hospital, where he's a pediatric urologist. Also, he did his medical school at Tufts University and then his residency with Dr. Arthur Smith, Dr. Gopal Badlani at Long Island Jewish. Now, as I mentioned, after doing his pediatric urology fellowship in Indiana, he is at Cincinnati Children's Hospital. He's going to talk to us about contemporary management of the neurogenic bladder. Dr. VenderBrink.
Well, as I said, thank you, Assem. Thank you, Dr. Desai. As a LIJ graduate, it is quite an honor to be here at this campus with the Distinguished Urology program here. Let's see. Is it the size of the yeah? What did I do? So, sort of an outline. Obviously, in the short period of time, we cannot talk about all of the management in neurogenic bladder, but I figured we'd kind of discuss the management goals in any patient, pediatric or adult, with a neurogenic bladder, and then just two brief updates in, say, the medical management as well as the surgical management. I would say that in order, any patient with a neurogenic bladder, we are tasked with preserving renal function, because as Dr. Reddy alluded to, and I will in a short period of time, the bladder can be hostile and deleterious to the upper tracts. We try to minimize any type of infection risk, and then lastly, we try to achieve urinary continence if it is not. However, we never want to achieve continence at the expense of the upper tracts, and that's an important dictum to adhere to. Any good diagnosis and evaluation begins with a history and physical examination. There are selective radiographic investigations that are helpful with ultrasound and cystography, but I believe urodynamics are extremely critical in these patients with a neurologic diagnosis leading to a neurogenic bladder. While urodynamics represent the cornerstone Dr. Reddy had alluded to before, and I will once again go over sort of the concept of storage and voiding pressures. These can serve to identify patients who are at risk, specifically in the pediatric stage in the newborn, but it really is only a snapshot in time, and I believe in the pediatric population that they are most helpful for a longitudinal perspective, and that changes can sometimes occur in children, specifically those with myelomeningocele, as the child undergoes somatic growth. And the thought process here is that the scar from the placode being taken down can sometimes tether the cord and affect basically the nerve function either in the lower urinary tract or pain or lower limbs. As you've seen in your studies of urodynamics, detrusor overactivity has a definition because you need to differentiate what is movement artifact. But those bladder contractions that are greater than 15 centimeters of water are defined as uninhibited detrusor contractions. Dr. Reddy had discussed about how this concept of an elevated filling pressure. This is a urodynamics from a patient who has myelomeningocele, and as we can kind of see from this, that the filling pressure beginning around 80 milliliters instilled starts to have a gradual rise. There's an annotation here where 40 centimeters of detrusor pressure is at 127, and then at around 76 there's a leak. But I find that these absolute values are less helpful than actually the shapes of the curves, which are hard to be represented sometimes in the literature, but you know, it's harder for kidneys to drain, as Dr. Reddy was discussing, when the bladder detrusor pressures are higher and sometimes can even surpass glomerular filtration pressure. This is the paper that Dr. Reddy was referring to in his talk. There were 42 adult patients that have a history of myelomeningocele. And what the investigators attempted to do is look at the concept of detrusor leak point pressure and then divide them out. And what they found is that ureteral dilation was still present in patients with a detrusor leak point pressure less than 40 centimeters, but it was far less frequent, as well as the incidence of vesicoureteral reflux. Hence, this paper, published in 1981, has served as sort of the reference of interpreting a urodynamic detrusor pressure and guiding papers. Another important topic when performing a urodynamic investigation is what is there synergy between the detrusor musculature and the external sphincter. And as you may know, that there's different ways to measure external urethral sphincter activity, either with needle, EMG, or patch. But in this image here, as we can see, there is a marked increase in this EMG activity with each of the uninhibited contractions. This was back also in the 80s, studied by Dr. Bauer, where that the initial urodynamics in newborns with myelomeningocele, when they found that there was a synergistic pattern, the risk of deterioration was relatively low, whereas the converse was true when there was dyssynergia. So this can truly be a helpful way to discriminate which patients are benefiting from a more active intervention at an earlier age. Now switching to these brief pharmacotherapy, we talked about maybe detrusor overactivity being a indication to begin this, as well as potentially the compliance of the bladder. Try to keep you all interested in some anatomy and physiology for the next two slides briefly. Cholinergic fibers do represent the largest sort of sympathetic innervation to the bladder, and the autonomic, and then this sympathetic innervation tends to be from an alpha adrenergic in the bladder neck, but there are beta adrenergic receptors in the body of the bladder. And lastly, the muscarinic receptors, which are activated by acetylcholine, usually trigger through intracellular cascades a contraction, whereas the converse is true when there is sympathetic autonomic innervation. Norepinephrine, actually through a cyclic AMP, actually relaxes. So an anti-muscarinic, such as oxybutynin, will reduce contraction, and however, there are lots of other side effects because this bladder is the only organ with a muscarinic receptor. The salivary glands, the GI tract, and such, that we have the most common side effects of dry mouth, constipation. Thus, Astellas has investigated the use of a medication with the generic name of Mirabagon that can actually be a beta-3 adrenergic agonist. And once again, in sort of a cartoon fashion, the Mirabagon is activating the receptor, going through a cyclic GM3 pathway to increase relaxation in the detrusor body. This does have some side effects. Hypertension is the most common, and I am excited to be participating in a clinical trial that is a multi-center one, where we're actually going to be looking at this in pediatric patients. Currently, this is only available in an oral tablet form, so this will be a suspension form, and there is a lot of concern from families and providers with the long-term anticholinergic effects in all these patients. So having an alternative way to deal with neurogenic detrusor overactivity or poor compliance will probably be a welcome addition. Now lastly, in switching over to surgical updates, at our institution, and I'm very confident at yours, medication and intermittent catheterization are used in all patients before we start to talk about surgery. But what if maximal medical management fails? And we still need to, as Dr. Reddy was saying, protect the kidneys or potentially provide urinary continence. But I would question, what is the definition of maximal medical management? That's up for debate. I will give you, as Dr. Megarian said, this is what I define as maximal medical. You are performing intermittent catheterization around every 3 hours during the daytime. You are on your maximal tolerable anticholinergic dose. Typically, I start oxybutynin around 0.2 to 0.4 milligrams per kilogram 3 times a day. So I do have some patients as high as 30 to 40 milligrams of oxybutynin, and at times I'll try to find different routes of administration. It'll be interesting to see where this new medication fits in. Sometimes in the settings of polyuria and decreased bladder compliance, I will have the patients on an overnight continuous bladder drainage, and I cannot understate how a poorly managed bowel can undo a well-managed bladder, especially in patients with a neurogenic bowel, as we see very common in spina bifida. But an ileocystoplasty is a highly effective operation to take care of these refractory patients. And as you said, so here a detuberized reconfigured segment, and there's a continent catheterizable channel to the Monty, and you take them out, and these are procedures that we perform. We do perform them, though, with some trepidation because there are a lot of complications. And this is a study from Indiana where they looked at 500 pediatric bladder augmentations and found that 1 in 3 of those children required another operation, not for their channel or anything else, but this is bladder surgery. Stones, rupture, secondary augmentation, perforation, early or late bowel obstruction, and 3 of the 500 underwent cystectomy for a ultimately lethal bladder malignancy. So botulism is used for several years, and this has also been used in pediatrics. As you probably know, its mechanism of action is to interfere with transmembrane proteins that are important in the release of acetylcholine into the neuroaxial terminal. With the disruption of that, there is no acetylcholine, so there is no contractions. What our center looked at with the help of one of our fellows was how well was this working in a pediatric cohort over a 5-year period. All of our patients were on intermittent catheterization and anticholinergic at the time of Botox. We excluded those where the Botox was into the external sphincter rather than body. And we were quite diligent about looking at urodynamics post bladder injection. So our technique was much like many other centers, trying to, it's multi-surgeon. So personally, I'm more of I inject my Botox submucosally rather than intradetrusor, but I know, speaking to my partners, that's not a uniform practice, and definitely with a retrospective review without standardization. We usually do about 10 units per kilogram because of a smaller child, and these were some of the results. This is a child where, as you can see, pre-Botox, there's a high contraction pressure around 150, and then post-Botox, a much more smoother, compliant bladder. This is a patient who was intolerant due to side effects from their anticholinergics. However, Botox is not very good for this type of bladder. This is a bladder that's pretty stiff from probably too much collagen. And as I said, Botox is working more on musculature, not on scar. So as you can kind of see, I didn't really think that this was much of a success for this patient. We did a total of 84 procedures in the 50 patients in our cohort. Some of them had multiple injections, and as you can see, the most common indication was more for urinary incontinence or some worrisome urodynamics. We were trying to avoid an ileocystoplasty in some of these patients. Overall, though, 50%, when you look at the metric of urinary incontinence, had improvement, and in fact, 45% were completely dry. As I was showing you with that urodynamics, those that were intolerant were much better than those who might have been a refractory, and it may be due to the detrusor or collagen. And actually, our effects were around 4.5 months, which is a little bit longer than probably the manufacturers. Others that are trying to think maybe around 3 months. Some of our patients actually got a little bit longer effects after multiple injections. So in conclusions, patients with a neurogenic bladder do require long-term, especially from the pediatric side, and that the medical therapy aimed at detrusor abnormalities diagnosed at urodynamics with or without intermittent catheterization may reduce the need for surgical intervention. And as I said, I look forward to sharing what we learned with this new beta agonist in the pediatric population. And Botox has really entered into the pediatric world as a second-line agent prior to the ileocystoplasty in patients. So, thank you.
Well, this brings end of the Pearl of Wisdom session. It has been wonderful. I think we never had so many lectures in a straight line on a pediatric urology, and all were so informative. I'm sure our resident would have been stimulated. Pramod, you remember 10-12 years ago I've been trying to get pediatric urology as a recognized specialty. Still we have not won. Pediatricians are still stronger, and we are still struggling with getting the specialty status. But that doesn't deter us from treating the patient with the children. Now Sabnis has been doing lots of reconstructive surgery. We are doing transplant. Not so much as you've been doing, but we have lots of reflux and simple things which we have been managing. But we would like in future, and our MOU still stands, and any of you would like to pick up pediatric urology, he has offered to fellowship for us to go and work in Cincinnati and then do that. Thank you very much, and I think it was a wonderful session today, and all of you had also had a good session of surgery, exposure to that, and I'm really grateful to all of the visitors for coming and blessing us with the knowledge and the stimulation. Thank you so much.